Good afternoon. My name is Suzanne Chambers. I'm the Executive Dean of the Faculty of Health Sciences at Australian Catholic University, and I'm delighted to be able to talk to you today about psychological distress and stigma for people with lung cancer. I'd like to firstly acknowledge my co-authors, Professor Jeff Dunn, Briony Scott, and Professor David Ball, who have supported me in pulling this presentation together. I have no financial disclosures or conflicts of interest in the materials included in this presentation. Stigma comes from society. It doesn't actually originate in the individual, and it's when society labels someone as tainted or less desirable on the basis of an attribute. And in the case of what we're discussing today, that's about lung cancer. It's important to be aware that power is central to stigma. And this, of course, is important for patients who feel like they lose a lot of their personal power when they're in a health system that is in charge of their health, their well-being, and in many ways, their future. When stigma is internalized, it becomes guilt or shame, and people can experience or fear discrimination. Now, the experience of stigma in lung cancer is shaped by the association, first of all, of the perception of the disease as self-inflicted. And of course, we've stigmatized smoking for very good reasons to help us reduce the incidence of lung cancer or work towards that goal. However, this will mean that by association, lung cancer is also affected by stigma. Beliefs about cancer and death can also shape stigma in cancer, and there are many fears in the community and very broadly about lung cancer as being a disease for which the outcome is poor. And in the past, there were stigmas about cancer as contagious, although that is less so today. Now, stigma is important to be aware of. It can lead to poor adherence to preventative measures. Why would I bother? What do I matter? Avoidance of early detection through fear of being stigmatized, and this can lead to a late presentation for treatment. So in lung cancer, health-related stigma is part of the experience of lung cancer, and this is well documented. It's connected to the idea of a self-induced disease that leads to a horrible death, and this becomes then linked to social isolation, fear that treatment will be denied or is undeserved, and can lead to a delay in reporting symptoms, and indeed in also leading someone to think they don't deserve supportive care. It's well established that lung cancer patients report more perceived cancer-related self-blame, guilt, and shame compared, for example, to breast and prostate cancer patients. Perceived stigma and self-blame can be partially explained by self-esteem and is related to anger, anxiety, and depressed affect more in lung cancer patients compared to other patient groups. If you have lung cancer, then stigma can lead to feelings of guilt, shame, a greater psychological morbidity, threatened personal identity, and impaired social life, reduced economic opportunities, and it can also profoundly affect families and significant others. And you will easily see in the media, in conversations in lung cancer support groups and through lung cancer advocates, people saying, why is it that when I'm diagnosed with lung cancer, the first question someone asks is, did you smoke? Which is a blaming statement for many. Now, people who work in lung cancer are very concerned about supportive care, and that's terrific and just shows the great connection of clinicians to the needs of lung cancer patients. And this particular review that was recently published is a good example of that, recommendations for supportive care in patients receiving concurrent chemotherapy and radiation therapy for lung cancer. But what I would point out is that if you read this article and go through the symptoms, nowhere do you read a discussion of screening for distress in lung cancer patients, the treatment of psychological distress in these patients, and managing the issue of stigma. So I would challenge this group to think about, we know that more than half of people with lung cancer experience high distress, and we know that stigma exacerbates this distress. Why is it that we are not recognizing this in clinical practice guidelines? Why is it that we are not doing something about this when studies have shown is it entirely feasible to detect distress through screening in multidisciplinary lung cancer clinics? So I would conclude by saying it is time to act. Stigma is social, contextual, and systematic, and we need action at this level, and working together with consumers and clinical partnerships, that's what we need to do. Health services, the lack of psychosocial care is a systems issue and a values question. Do we really acknowledge and are we going to act on our understanding of the psychological needs of people with lung cancer and their families? Again, we need a partnership between consumers and clinicians to make this meaningfully change. And then action. Action is the fact or process of doing something. A thing needs to be done. This is what we need to do. The time to act is now, and I thank you for your attention.